with me in welcoming from Sheffield University and Children's Hospital, the one and only Professor Nick Bishop.
Right, well thank you very much Patricia for the fantastic warm-up, and nice to see you all. Okay, I'd like to talk to you about medicine and treatment. And some of you very kindly filled in or responded to a query that was sent out through the Little Bone Society about what sort of factors would you take into account when you were deciding whether you wanted to take a treatment for yourself or accept a treatment for a member of your family. The reason I want to talk about this is because it is the case. Treatments that we have for OI have just come down to us effectively from what is used in adult osteoporosis. None of these treatments that are currently available or which are being talked about as being the subject of research trials in the near future have actually been developed specifically for OI. So, why is that? Well, I'll give you an example of a medicine that has been developed more specifically for children and for a particular condition, and then perhaps that will illustrate what the scale of the problem is. There is a condition called hypophosphatasia. It's another rare bone disease. It's much rarer than OI. If you're born with it, and it's apparent at birth, your chances of making your first birthday are 0. If it becomes apparent within the first 6 months of life, your chances of making your first birthday are around about 50 to 60%. So it's really severe when you see it early on in life, a bit like OI. About 10 years ago, a very clever research group in Montreal invented a way of replacing the missing thing, which is an enzyme, and they were very clever. They attached the enzyme to something that made it bind to bone and kept it in the bone tissue. The drug was tried in mice, and then it was given to some children. It's been phenomenally successful. The drug is called aspartase alpha now, and I think about 30 people have had it altogether so far. There are, to my knowledge, about 20 babies who would have died who've taken this treatment and who've not only survived, but grown and developed. Their bone disease has almost gone away. But the company that originally developed the drug was called Inovia. And about 2 years ago, it was bought by another American company. Having treated 30 patients, they paid $1 billion, the company. So for them to make that money back, in terms of selling the drug, is going to take a while, because this is a very rare bone disease. We only get maybe 2 or 3 children born each year in the UK with it. And so the cost of that drug is going to be phenomenal. Under those circumstances, there is a very clear case of need. If these children are not treated, they will die, or be very severely handicapped. Now, I think we could make a similar case for osteogenesis imperfecta, certainly around the severe end of the spectrum. But there hasn't been any targeted treatment for OI as yet. Hypophosphatasia is due to the lack of a single protein which has a specific action in bone, and when you replace it, you restore that action. OI is much, much more complicated. For most of the folk here and around the world who suffer with OI, the problem lies in the manufacture of proteins that form building blocks within the bones, the matrix. looking at how the changes that occur interact together to create what actually happens in your body and gives you a why is very complicated. And it's not something that we're going to solve with a single revolutionary new treatment, I don't think. But I think there are things that we should be doing better to try and look into it further. You can see, though, that a drug company isn't going to invest $1 billion unless they've got something they think is going to be a winner. Because the commissioners, the people who pay for the drug, in this country, this is basically for OI it would be what they call the highly specialised services. They've got to have the money to pay for it, and they're only going to pay for it if they can see from the information that it's going to work. So at the moment, they'll pay for us to do things like bisphosphonates, physiotherapy, occupational therapy, nursing support, psychology, social work input. They'll pay for us to train doctors to, work in those teams and to integrate all of that activity together. In terms of new drugs coming on, though, at the moment we are still going to be looking at drugs that have come down from the osteoporosis community, not new drugs that are specifically targeted towards OI. So one of the things I was hoping for when I got Patricia and Elaine to circulate this question was, actually, what is it that you guys want from treatment? We know what we can offer, but let's say that you had a clean sheet of paper and you could say, what I want from the treatment is the following. So some of the answers I've got are quite illuminating. So I'll try and read some of them out if I just need to put my glasses on because I'm getting old. So somebody said, I have bone pain, but the pain and rigidness of taking the above medication is unbearable. I'm assuming this would be the bisphosphonate. Give me a fracture any day, so I can cope with that. So I wasn't quite sure how to take that. But then there are other things. People are saying things like side effects. How long would they last? Is the treatment going to be successful? How would you take it? How often would you have to go and see your doctor? How much time commitment would it involve? When you do these scans on us to measure our bone density, how good are they? Are they really accurate? Do they tell you what you want to know? Chronic pain. Side effects, pain. Pain keeps coming around as a problem. Side effects and interactions with other drugs. Whether other OI people have taken it. Side effects, risks versus benefits. And then this is the one. Who's prescribing it and can they be trusted? Okay. But you get the picture that people, anyone who's faced with taking a new medicine is going to be worried about the possible side effects, both in the short term and long term, and the risks and the benefits of taking it. If new medicines do come along, because they're new, we won't be able to give you very much information about long-term side effects, because we won't know. We'll be in the same situation we were 15 to 20 years ago when bisphosphonates were first introduced. And we will have to say to you, we will keep you up to date with everything that happens to people who take these medicines, but we can't guarantee on an individual basis that everything is going to be fine, because they're new. So that would be research, that would be participating in, if you like, an experiment on yourselves. to see if things could be better. And sometimes people will feel that's justifiable, but sometimes they don't, and that's entirely up to you. Nobody's going to make people participate in research that they don't want to be involved in. I wanted as well just to talk to you about what we are doing to try and improve that situation. You'll probably be aware that the European Union gives a lot of money out every year in research grants. And the current major programme of research grants within the European Union is being given a name, and it's called Horizon 2020. And within that, they have literally got billions of euros that they're going to spend on research, not just in medicine, but engineering, social things, all sorts of stuff. There's one specific call that is out currently called PHCAT, and it's to look at the long-term effects of medicines in children with chronic conditions. To sort of go around and ask people, have you been taking your medicine and what effect has it had on you? Because within the core it's quite clear they want us to be a bit more innovative than that. So what we've done is to try and join together 6 European centres that can do a variety of different things. All the way from looking at patients and understanding how their treatment has affected them, to right at the very basic level, trying to pull apart and understand pathways at a cell and molecular level that cause OI and problems that come with it. If we were successful in getting the grant, it would be a lot of money. What we would want to see from it, though, is that we create a system in which we can develop new medicines that are specific for OI. Not so much medicines that will then be used for adult osteoporosis, but things that will really help people who have OI as a specific condition. Because that's, at the moment, something that I think is severely lacking. In the meantime, there are lots of other things that are happening. There are funding groups within Europe, and there's Dagmar Mecking here this evening from Care for Brittle Bones in the Netherlands, whose group is funding research projects in Europe and beyond Europe as well, looking at different aspects of OI. One of the things I think that needs to be dealt with in the meantime, while we're hopefully developing all these new medicines, is to deal with these issues around pain. Pain and fatigue seem to be the most limiting things for the majority of people with OI. It's not just adults who complain about it. Elaine was telling me that her daughter was saying when she's been out with her mates, she can't keep up. Towards the end of the day, it gets to the point where she's tired, and then she gets frustrated because she's sort of lagging behind and not able to keep up and enjoy herself. So pain and fatigue are things that are commonly reported in folk with OI, and it doesn't seem that we've been very good at dealing with that a lot of the time. People, when they've taken their, if they've had permethrinate or something like that, they say they feel much better for a while afterwards, and then the pain and the fatigue come back. When we move children from permethrinate over onto risedronate, we often find that that tends to ease as a problem. Risedronate provides better, if you like, background pain relief. But there's nevertheless a bit of a ceiling for a lot of folk. They don't feel that they can push themselves as much as they'd like to. But pain and fatigue slow them down and get in the way of the things they really like to do. So my suggestion would be that you tell us, from that blank piece of paper, you write down a list of the things that are most important for you as a group of parents and individuals with OI and young people with OI. Tell us what it is that you really want us to sort out of all of these sets of problems. Give us a list. Give us some targets, objectives, things that make a difference to you. Because in the end, unless you speak up, all you'll get is the leavings from the osteoporosis table. We'll just get more drugs handed down to us that are designed for adults who've got a degenerative bone disease, which does not give them pain and fatigue and the other problems that you experience. Okay? So we need to be able to do better than that, but you have to be the ones who have to shout loudest. It's all very, every single doctor I've ever met is passionate about looking after their patients and perfectly happy to put their hands up and shout for them. But the voices that count are your voices, in actual fact, in terms of changing what happens at a policy level. I went to a meeting with NICE, the National Institute for Health and Clinical Excellence, around the introduction of this new drug, a very expensive one for hypophosphatasia. Alexander Kemp from the Genetic Alliance was there as somebody to speak up for the patient group, if you like. You have to tell people like that what it is that you want. Okay? That's the way your voice is going to get heard. And that's how things will change. Because the regulators will turn around and say to the drug companies, you might think that increasing somebody's bone density is a good thing. Okay, we don't disagree with that, but actually what matters to the patients is the following list of things. And we want to see you report on those in the outcomes for the drug trials that you do. And if your drug doesn't meet these specific objectives, then we're not going to fund it. Or we're not going to look at it as favourably. Okay? But you guys, you need to be the ones who are putting your hands up and making your voices heard. So my plea to you would be that if you have the opportunity to do that, then please take that opportunity. And that might be spending a couple of minutes answering another questionnaire that we send around to you. It might be participating in observational work, like the Rudy project that Cassim Gervais is running from Oxford, which is again, it's an important part of trying to understand OI better, because he's going to collect information about what are the top 3 things that really make your life difficult with OI, alongside all of the other information. We want to know how to make things better. The best way we can do that is to ask you, and for you to tell us in a very unbiased but very forthright and clear way what you want. Okay.